Welcome to the Radically Genuine podcast. I am Dr. Roger McFillin. The power of the mind to heal the body has long fascinated scientists and philosophers alike. The placebo effect, where a person's belief in a treatment can lead to real physiological improvements, is perhaps the most striking example of this phenomenon. Studies have shown placebos can alleviate pain, reduce inflammation, and even improve motor function in Parkinson patients. In my field, the placebo effect is powerful in mental health. In some cases, placebo treatments have rivaled the effectiveness of actual drugs. This isn't just the power of positive thinking, it's the brain actively participating in the healing process, releasing its own painkillers and altering neural pathways. But how far does this effect extend? Could it be influencing outcomes in more invasive medical interventions? Is it possible that some surgical procedures, with all their cutting-edge technology and skilled practitioners, might owe a significant portion of their success to this same phenomenon? Today, we are joined by a guest who's uniquely positioned to explore these questions. He argues that many common surgical procedures, from knee arthroscopies to back fusions and cardiac stenting, may not be as effective as we think when subjected to rigorous scientific scrutiny. He suggests that in some cases, the expectation of healing from surgery might be driving positive outcomes. Could be more than that. We're going to get into this more. His name is Professor Ian Harris. He is an orthopedic surgeon in clinical practice in Sydney, Australia. He is also a professor of orthopedic surgery with a PhD in evidence-based medicine and surgery. He directs a research unit that focuses on outcomes of surgery and has published and presented widely in the field of surgical outcomes. He is the author of Surgery, the Ultimate Placebo, and co-authored the book Hippocrasy, How Doctors Are Betraying Their Oath. Professor Harris, welcome to the Radically Genuine podcast.
Thanks very much for having me.
Now, the title of your book certainly caught my attention. I understand the power of placebo in a number of health conditions, most especially in my field in mental health, as well as experiences with pain, but I'd never really considered it in the role of actual surgeries. Now, how do you define the placebo effect? How can my audience members really kind of understand what this means? And boy, how does it relate to actual invasive surgeries where we can objectively measure the actual physiological changes?
Well, firstly, by and large, we don't objectively measure the changes. So most of the surgery, for example, that I'm involved in is treating pain. And so we are relying on subjective measures where placebo may have more of a role. But to define the placebo effect very much depends on your definition of placebo. And the terminology gets very confusing, and we are actually moving away from the term placebo because of the confusion that it causes. By definition, a placebo has no effect. So when we start talking about a placebo effect, it doesn't make sense all of a sudden. And so I think what most people are talking about when they talk about placebo effects, and the definition I used in the book, is non-specific effects. So anything other than the specific effect of the drug, the surgery, the procedure or the intervention that you're having. So surgery may or may not, depending on the circumstances, have a specific effect on the underlying pathology that will influence the patient's outcome. There's other non-specific effects that are not related to the surgery. And you can call them placebo effects, but I think it's probably cleaner and easier to understand if you break them down into things like the natural history of what would have happened to the person anyway if they'd been left alone, and contextual effects. And this gets very close to what a lot of people tie into placebo effects, and that's perhaps the interaction between the therapist and the patient's expectations, the environment or the setting that the treatment is in. These things can influence a patient's outcomes, but they're not placebo. They're not nothing. These are tangible things that can influence the outcome. And so, yeah, it is confusing with the terminology. And so, I think it's better to talk about specific and non-specific effects of the treatments that people receive.
Okay, we'll definitely get into that. Let me ask for some clarification, though. So, wouldn't we, in a well-designed study that's controlled, that is blinded, that's standardized, wouldn't we be able to control for, let's say, like natural recovery by including a non-treatment control group or a waitlist control group?
Yes. And so the best studies to tease out these effects are studies where we have 3 arms. So this is an arm where patients will have the full treatment, say the surgery. Another arm where patients will have a placebo operation, where they don't know if they've had the surgery or not. And a third arm where they don't receive anything. No placebo, no treatment, just how are you going?
Yeah, so let me just explain my field, which is clinical psychology, and I've done a lot of research on antidepressants. And one of the things that is very clear for me when I examine the totality of the research is that we can't really differentiate the placebo groups from the antidepressant group with any real clinical relevance. And basically what's that saying is when someone actually is provided an inert substance, a sugar pill, for example, they do make some substantial improvements. And my understanding of it is my belief around this is it's around that expectancy effect. So their belief that they did actually receive the substance can predict their clinical outcomes. For example, the TAD study, which is the Treatment of Adolescent Depression Survey, what they had was they had the participants, the adolescents, their parents, and the researchers, who were the prescribers, actually predict, did the person get the placebo drug or did they get the actual antidepressant drug? And the interesting finding from that was if the teenager, for example, believed that they received the antidepressant drug when they indeed only received the placebo, their outcomes were better. And it was vice versa. If they actually believed that they received the placebo when they indeed only received the antidepressant drug, their outcomes weren't as strong. So I always see the placebo as that power of expectancy, of like the power of the mind. When you believe that you've received the treatment, it's got some actual measurable effect.
Yeah, and there is evidence that patient expectations do drive outcomes. That's true. But it's interesting, some of the what we call open label placebo studies, where patients are told you are getting a placebo. And then they look at the improvement afterwards. Often in those studies, they'll have 2 arms, and one arm, the group that gets the placebo treatment, are also given a video showing them how much better they're going to get. Or they're told, and in fact, the script for some of those open label placebo studies is things like, you are receiving a placebo. These have been shown to be highly effective for your condition in scientific studies. And that's the difference between the 2 groups. It's not the pill. The pill itself doesn't actually contain anything. It's the management of expectations. It's the setting, and a lot of it is what you've said.
So I'm actually curious what spurred your interest in this area. Like how, how did you actually start getting focused in this area in surgery? It's not that widely known or discussed.
What interested me was I was a general orthopedic surgeon. So I was doing lots of operations and I wasn't really up to speed with the science. And we are not trained as scientists. I didn't have a good understanding of how to interpret the literature. And I knew that there were some questions around effectiveness. I wanted to be more scientific in my practice. And so I just started to question things a little bit, and I was very impressed with surgeons, the very few surgeons who were able to interpret the scientific evidence. And I didn't have that skill, and I wanted to get that skill. And so that's when I went off and learned evidence-based medicine. I did a master's of clinical epidemiology, and then went on and did other things. And then I started doing the studies myself. But at around that time, I was seeing problems with what I was doing. So, for example, I was doing lots of arthroscopic knee surgery, like everyone else was. It's one of the most common operations in the world. And I was doing so many of these operations that I developed a waiting list, and patients were waiting longer and longer to get into the operating room. And it got to the stage where I would be seeing them 3 or 6 months later in the anesthetic room just prior to going in to have their surgery, after having not seen them for a few months. And I'd say to them, how's your knee going? You know, how are you? And they'd say, oh, it's fine. Yep, it's really good. No problems. And so many patients would not have any problems with their knee, despite the fact that I'd booked them for surgery 3 to 6 months earlier. And that's because that's often what happens when you leave these things alone. And so that's the natural history of a lot of conditions that we treat for pain.
So with arthroscopic knee surgery, often there's like a meniscus tear, or there's something that is clearly needed, looks like it's in need of repairment. So what happens in that natural recovery process?
It's all about the terminology. And the problem is we use the word torn. And people see a torn meniscus like a rent or a cut in your clothing. You know, you need to sew that back together. Otherwise, it just won't work properly. It'll have a big hole in it. But in reality, meniscus tears are by and large degenerative in nature. They're wear and tear. They're like the patches on your elbows or your knees that over many years will just all fray and fall away. And that's not something you can fix with a stitch. And in fact, what we do is we remove the meniscus when we do that surgery most of the time. And so how does removing more of the torn clothing help? You know, it doesn't. And so this is largely a degenerative condition. It's often associated with osteoarthritis, and the meniscus tear is just a sign that the patient has osteoarthritis, which is causing their pain. And repairing it or removing it doesn't make any difference to their pain, because it's not the cause of their pain. It's something we can see on a scan. And we fall for that trick all the time in surgery. We have someone with chronic back pain, we do an MRI. The MRI will always show something. Even if the patient doesn't have back pain, the MRI will always show something. And so it's human nature. It's a bit naive, but it's human nature to say, oh, well, there's something on the scan and the patient has pain. Therefore, the thing that I can see on the scan is causing the pain. And mostly it is not causing the pain. Chronic back pain is very complex and often not related to a single, simple physical cause.
This is fascinating, because my son, who's an athlete, was just recently recommended to get arthroscopic knee surgery, and we actually declined, and he's doing fine. But why would we then do so many of these scopes on young athletes, for example?
Well, they often have different conditions. So, yeah, for example, we often do arthroscopic surgery to reconstruct torn ligaments. And that can be very helpful for people who have an unstable knee because they've got a torn cruciate ligament. Sometimes people can have a very large, acute, torn, good meniscus, and a young person's meniscus, and we can put that back in place and put some stitches in it, and it might help their symptoms. So there is a role for these things, but the problem is most arthroscopic knee surgery is done on older people with arthritic changes, and for them, it offers nothing.
This is fascinating. So I want to go back to something you said earlier, and you talked about the 3 arms to a study, and one of them being the placebo in the surgical aspect of the clinical trial. So what would that then look like, let's say for arthroscopic knee surgery, if you were going to provide a placebo?
Yeah, so there's been quite a few placebo surgical trials at the moment. We're running one at the moment for shoulder surgery for rotator cuff repair, which is a little bit different to the knee ones. The placebo or the control group can vary quite a lot. So, for example, in one of the most famous knee ones done, the knee study that was published in the New England Journal of Medicine, they did an arthroscopic meniscectomy. They cut out the torn meniscus. This is in patients with a torn meniscus. They cut out the meniscus in the active group, in the treatment group, and in the control group, they made the incisions. They put the camera in, and they looked around the knee, but they didn't touch the meniscus. They didn't cut it away or clean it up or remove it or repair it in any way. They just left it as it was. So that was the placebo group, or what I'd rather call the control group, because, again, people don't understand what placebo is. It's better to say what it is. So we're doing a study at the moment in rotator cuff repair, which is repairing frayed, degenerative, again, torn, and that, unfortunately we use that word torn because it makes people want to have surgery, rotator cuff tendons in the shoulder. This is a very common condition. Most people over the age of 60 actually have a torn rotator cuff. So it's extremely common. And so we're doing a study that was initially called a placebo-controlled randomized trial. We've removed the word placebo, and what we've called it is a randomized controlled trial of arthroscopic shoulder surgery with rotator cuff repair compared to arthroscopic shoulder surgery without rotator cuff repair. And to me, that's just a lot simpler, and people know what we're doing then. And so we are doing arthroscopic surgery. We're cleaning out the joint. We're inspecting the cuff. We're trimming away any bone spurs that we see. And then patients are being randomized to have the rotator cuff repaired or not repaired. And when they wake up, they won't know what they had done. They see a different surgeon afterwards who won't know what they had done. They all have the same physical therapy afterwards, but the therapists don't know what they had done, and so on and so forth. So that, to me, is scientifically the best way of finding out whether actually repairing the rotator cuff makes a difference to patients or not.
So if that's kind of the gold standard, then how have surgeons been making decisions, and what has been the evidence to determine how they make these clinical decisions?
Very good question. The evidence for surgery is largely observational. And scientifically speaking, I use the term observational to contrast that with experimental. In other words, a proper scientific comparative study. So the observational evidence that surgeons rely on is that they see people get better. The surgeon that taught them did the same thing. Their colleagues are all doing it. So this seems to be the way that this should be treated. And mostly orthopedic operations develop without experimental evidence. And because the natural history of a sore knee is that it won't be sore 3 months later, when we operate on every sore knee that we see, then most of our patients will not have a sore knee 3 months later. And if we operate in between, then we attribute that improvement to the surgery. But that's a logical fallacy, because we're not seeing what would have happened had we not operated on them, which is what I started to see when I had patients with a long waiting list and suspected that something was up.
So take me into the mind of a surgeon. I'm assuming at this point that a lot of surgeons want to do surgery. They believe in what they do. They've gone through very rigorous training. They feel like they're very skilled, and they believe they can help their patients. So how are you received in your surgical community with this kind of understanding and discussion? And how can this then inform the training of surgeons? And is there any kind of for the lack of a better word, resistance to these type of ideas?